It's Dr. Towfigh. Welcome to HerniaTalk Live. I'm your host, Dr. Shirin Towfigh. Many of you are joining me live on Facebook. I'm at Dr. Towfigh. You may be on the Beverly Hills Hernia Center site. As you know, this and all prior episodes are available to watch as a YouTube on my YouTube channel at HerniaTalk. And if you're like me and you like to watch or listen to podcasts when you're driving to work, I even do it on vacations. This is also available as a podcast. So if you like the podcast, please like and share, and that way more people can get to watch it. So I'm really excited because we have a great guest today. Her name is Dr. Karen Zaghiyan. I've known her for, well, I don't know. She's going to have to tell me how long I've known her. I'm going to say close to 16, 17, 18 years.
I think so.
She is a colorectal surgeon in Los Angeles, one of the premier ones because she is very, very caring and knowledgeable at the same time. You can follow her on Instagram at Dr. Karen Zaghiyan underscore official, or on Twitter at Karen Zaghiyan MD. And here she is. Hi, Karen.
Hi, nice to meet everyone. Thanks for having me, Shirin.
Of course. So Karen kind of has a practice like mine in that in addition to her training as a colorectal surgeon, she inherits complicated patients no one else can figure out. If someone needs help, they usually call Karen. You're just very approachable, kind, and knowledgeable and skilled. So it's like a quadruple threat, I guess you can call it. So she answers my calls and my texts when I call her. It has always been helpful, and we've shared some really complicated patients together. So if any of you are on TikTok, what is your handle on TikTok? Do you know?
I think that's a good question. I think it's the same, but my Instagram handle went to official because I got hacked.
Yeah, so she's so popular, she got hacked, and so she had to change her name to
TikTok
at Dr. Karen Zaghiyan underscore official. So is that the same thing for TikTok?
The same thing.
Yeah. Okay. So I follow you obviously, but if you follow her this past week, she went on a little bit of a rant because, well, maybe you can explain what your rant was.
So I had a company that came out to try and sell me a device. And their selling pitch for this device was, well, the OBGYNs are using this to treat people's hemorrhoids all the time. And you guys, my jaw was literally on the floor when I had heard that. I was like, wait, what? And she was like, yeah, the OBGYNs are using this and they're seeing really great results for people's hemorrhoids. And I didn't know what to feel. I was appalled.
Because to clarify,
OBGYNs are not trained on hemorrhoids. They're trained on the anal canal. Yeah, that's in the same area. Like, we get referrals for hemorrhoids a lot from OBGYNs.
Yeah, because of
hemorrhoids are a common complication of pregnancy. But they're not experts in, deciding what to do for somebody's hemorrhoid. Like, if they can get the diagnosis correct, that's amazing, but that's not necessarily accurate most of the time either. Because any growth in the anus is commonly just labeled a hemorrhoid. And so here I am thinking like, oh my God, there's patients that have like, who knows what they have, being labeled as hemorrhoids and being treated in an OBGYN practice. Now, I don't personally know of any OBGYNs that are using this.
Yeah, I've never heard of that. That's crazy. But the rep is telling you all the time.
Yeah, exactly. And that, their patients feel great with it. So I should use the device.
Oh my God. That is so scary. But you know what? This is the issue that I hear as well. So you did this post on TikTok, and I was like, I need to bring her on because the energy that she has right now is the energy I have every single day when I'm in clinic. Because there are people that are doing things that are I can't say necessarily that they shouldn't be doing it. Some people that they shouldn't be doing it, but they're definitely not specialists. And something that I always say is find the specialist and then that you like, and then trust the recommendation instead of saying I want X and then try and find a doctor who's willing to do exactly what you're telling them to do. That's what is in my
Yeah.
feeling. I want a non-mesh repair, and yet they have this humongous hernia or like, and then they'll find eventually someone who's not an expert that's willing to take their money and do a procedure they're not an expert in. And it's just, when you said it, I was like, oh my God, this is exactly what's happening in our specialty. It happens in your specialty. It's
Yeah, it
frustrating.
really, it's very frustrating. Because we see it on the other end, you know, and when you get a referral, like you don't want to badmouth another specialist. You don't want to say to the patient that like somebody did something wrong. Um, and it's not even just doing the wrong thing, but it's like not having all the options. Like when I
Yeah,
think of like who's an expert in this thing, right? You think of like I think of Dr. Towfigh as like a hernia expert, right? So like if I have a patient that has a complex hernia, she's going to figure out what the best thing is for that patient.
yeah.
I don't know, but she knows, right? So if she only did one particular type of repair, then that would maybe make her not an expert,
Not the
if that
specialist.
right,
Well,
not a specialist.
one thing you mentioned in your post was when you're going to see a specialist, like there are a lot of people that call themselves hernia specialists. As you know, around me, ever since I opened up my hernia center, there's like 15 other hernia centers, which is a lot of it is a marketing ploy. But to be a true specialist, and I've mentioned this before, you should be able to, like in my field, you should be able to offer open, laparoscopic, robotic, with mesh, without mesh, groin hernias,
Yeah.
belly hernias, rare pelvic hernias, like the whole spectrum. So when a patient comes in, I can say, okay, you have this entire menu, but in this menu of operations that can be performed, this one and maybe a second one is what I recommend for you because the rest are not appropriate, for example. But if you're only doing one procedure, then that's not being a specialist.
Yeah.
And what
Yeah, I
you were
agree.
saying is to offer the whole spectrum. You do anorectal, you do colon cancers, you do, congenital problems, right?
Yeah, and I mean, even if you take the single one diagnosis, like let's just make it simple and say hemorrhoids, right?
Yeah,
Like let's just say I'm only a hemorrhoid specialist, right? If I'm a hemorrhoid specialist, I should be able to offer all the like I should be able to do sclerotherapy, I should be able to band, I should be able to do surgery, I should know the different kinds of surgeries that are appropriate
mhm,
based on the patient and like what they have, right? Somebody that has external hemorrhoids doesn't need the same surgery as someone that has prolapsing internal hemorrhoids. So,
yeah,
like, to really that way, when I see the patient, I could say, okay, out of like this toolbox that I have that is for hemorrhoids, which one am I going to select for this patient based on what
yeah,
they have, what they want, whatever. But if you
yeah.
only like are trained to do in general surgery, like we trained on doing excisional hemorrhoidectomies. Like we learned that in general surgery, right? So,
I
can
mean,
you
I've done
take
hemorrhoidectomy, but
what?
I was in my late 20s. That was a long time ago.
Yeah. So
I
if
will
you
never do a
know when to
hemorrhoidectomy
take,
ever. You can pay me
exactly.
a
And I,
billion dollars. I won't do your hemorrhoidectomy.
yeah,
Yeah. So the question that sometimes the patients ask is, as a patient, how do I know if my doctor's a specialist or not? They say they're a specialist on their website, or they seem nice, or my medical doctor referred them to them. I mean, there's a lot of surgeons that are very nice surgeons, and they get referrals because they're easy to approachable, they're kind, etc. But they're not necessarily specialists. So what's the answer when the patients ask, how do I know if my doctor is a true specialist or not?
I think it's hard to navigate that as
Yeah.
a patient.
Yeah.
I think one of the things you could do is look at, board certification. Now, I know in like hernia, right, there's no board certification, but in
Yeah.
colorectal, there's board certification. So looking to see, I don't know if there's other kinds of certification or something that you get, based on whatever in hernia
Well, I
surgery.
mean, you can check to see if they're, first of all, always make sure that they're licensed. There are plenty of unlicensed doctors out there.
Right.
Things. And then you can look at their, maybe their education, see if they actually did a fellowship in colorectal surgery, like you said. In my case, uh, there are people that are not even finished general surgery that do stuff, but that's usually uncommon. And then board certified in general surgery, board certified in colorectal surgery, right? You guys have a board, right?
Yeah, we have
Yeah, yeah,
yeah, so
yeah,
we're dual certified. So we're general surgery certified, but then we're also colorectal surgery certified.
yeah,
And it's not uncommon that somebody says board certified, but you want to dig deeper. See, that's the part that it's hard as a patient to navigate. Like, how's a patient supposed to know that like colorectal has a separate board, and like if I have a colorectal condition, I should be looking for a boarded colorectal surgeon, but like
yeah,
hernia doesn't have a board. Right? And you're
yeah,
just looking for a but for a general surgeon, but then maybe
yeah.
like MIS. I think MIS tends to be
Yeah,
right.
like a laparoscopic fellowship that could help, right?
Yeah,
We have societies. Sometimes
right.
I say if a surgeon is part of a society, sometimes that implies they have an interest in that topic, right?
Publications,
Uh,
not every surgeon is academic necessarily and like
yeah,
publishing, but if they have publications in the topic that you're looking to get treated, I think
yeah,
that is definitely a bonus and implies that they have expertise.
yeah,
Also, not every doctor who publishes is a good surgeon, so you kind of have to put
that's
all of
true.
them
That's the problem.
together and yeah.
Yeah, that's a problem. And then I don't know, I think even though Yelp and all those are not exactly indicative of a great surgeon, but if they have like a 3 or lower score, definitely
Well, I
don't.
think you can also look at the reviews and see what they're saying. Like if you look at like I have good reviews. I have really great reviews
Yeah,
online, but I have some negative reviews.
yeah,
And most of the time if you read it, it's like it's meaningless, right? Like it's not a substantial thing. Like I don't know.
yeah.
The
I
doctor
have someone who
diagnosed the wrong thing and like I don't know. Yeah.
wrote me a bad review and said I was like popping potato chips during the exam, and I'm like, how is that even possible? Like, is that not even credible? First of all, I don't eat potato chips, but even if I did, I wouldn't eat it
Yeah.
during a physical exam of a patient.
Yeah.
So, patients usually read those things and like, that's not credible. Yeah.
What about referrals? If it came from your trusted primary or is that
Yes and no. I don't know about those. A
yeah,
lot of the referrals, it has to do not necessarily that you're a specialist, but like there's a personal relationship with that
yeah.
doctor. And that could be because they shared patient care and they have a great experience, or they both go golfing at the same country club. I mean, it's unclear. That part's unclear.
Yeah.
I say always get if you're
Opinion.
contemplating surgery, get two opinions.
Yeah.
I mean, I've had my own surgeries. I know exactly who to go to. I
Yeah.
still went and got more than one opinion.
Yeah.
Just want to make sure.
Yeah. Totally.
Yeah. Here's a question for you. You said research papers in the field is important to indicate a specialist. There's a doctor who wrote a book regarding his field or her field, but no peer-reviewed articles carry the same weight to indicate a specialist.
That's a good I mean, I think if they've what kind of a book?
Mystery book.
A novel? A novel?
There's a lot of time that needs to go into a book.
Yeah.
I would add that.
Yeah, totally. Yeah, if it's a legitimate book, um, I think so.
I mean, there are certainly people that write promotional books, but I would say in general, that's usually an indication they have a special interest at least.
Yeah.
Yeah. Do you think that um, it's always important to go to a specialist? Like,
I would want that. I mean, for
yeah,
myself, I would want a specialist,
yeah,
especially if one exists. If a specialist exists, I think and you have access to a specialist, I think it's important to do that.
yeah. I would say that the same thing, but it costs money. I understand that, but nowadays at least you can do telehealth, so you don't have to necessarily travel all over to see a doctor. So that's a positive since
Yeah.
COVID. A lot
I mean,
more
I do
people
that
are
all the
opting
time. Like I'll have
for health.
patients call in and they're having surgery somewhere else and they just want to, get my opinion as to whether the plan is what I would do.
Uh-huh.
And they're not necessarily willing to like travel to do the surgery. But they just want to make sure the plan that's set forth is appropriate. I think you can always do that, even if it's not feasible to like, you know, leave where you're at or go
Yeah,
outside of your insurance.
yeah. The other thing is skill.
Oh yeah.
So that's a hard one.
That's a hard one.
Yeah. I think as I have a friend, she was proctoring another surgeon. So when you proctor, let's say you have a new surgeon in your hospital, your new surgeon is mandated to perform a bunch of operations and have it be proctored by someone who already is privileged in the hospital, so the hospital can assure that that's a skilled surgeon. So she called me and she's like, "Dude, this was a hernia, and it was the worst performed hernia. As a proctor, you're not there to teach them anything. It's observational." But she was telling me about how this is a surgeon who's not even a junior surgeon. Like the surgeon was been in practice elsewhere before, and they picked the hernia for to be proctored, and she said it was like
Yeah.
one of the worst. And she's like, I I've never operated with these people, so I don't know how other people do it, but she assumed
Yeah.
people did good hernia surgeries. I said, nope,
Yeah.
that's
I
that's
mean, I
not.
think the other thing, I always say the thing to ask, right? And people ask this is, I used to get asked a lot until I got all my gray hair that, how many years have you been out in practice? But I
Yeah,
think the more important question is like, how many of these cases do you do monthly? How many of these cases do you do yearly?
yeah,
And then also knowing like that surgery is, right? You might have a very, very rare thing that's being done, and maybe it's not that common, or you may have
yes,
a very common procedure that's being done. I'll tell you, like in our field, J
yeah.
pouch surgery has
Oh,
dropped so significantly to the point that our fellowships are now we're actually only required to have our fellows do 3 J pouch operations.
really? That's
Fellowship.
for ulcerative colitis?
Yeah, so J pouch surgery, for anyone who doesn't know, is like it's when patients have severe ulcerative colitis or for like familial polyposis, where the entire colon has to be removed, and then we have to reconstruct the small intestine into a new rectum and then attach that down to the anus. So it's pretty much like that, and like rectal cancer surgery are like the two probably most complex surgeries that we do in our field.
Yeah,
Uh,
yeah.
and because of, improvements in medical therapy, the number of patients that are having this operation has dropped very significantly.
No
And so
kidding.
our board had to make a very difficult decision because, people were not completing their numbers and fellows were having to like leave their institutions and go out to like, tertiary and quaternary centers to get their J pouch numbers. Our board had to make the decision to like say, okay, so if you do 3 J pouches during your fellowship, you're allowed to graduate. Now, hopefully that person is not going to now like the person who trains at the low volume J pouch center, hopefully is not then going to go out into practice and like be offering that surgery to patients. But like, how would you know as a patient, right?
How do you know?
Um, And it's the same with our rectal cancer numbers. Like in rectal cancer, with the really great improvements in chemotherapy, radiation, and now like we do watch and wait, kind of like what we do for anal cancer. We're doing
Oh,
it
cancer?
for rectal cancer. So we give chemo radiation, and like a lot of, probably about 40% of patients have a complete response and don't need surgery at all. So our numbers have tanked. So now it's become even more and more important that like if you're selecting a surgeon, you're picking somebody who does that operation a lot, and sees that volume a lot. In cancer, it's kind of like, one way to know is, was your case presented at a tumor board at a multidisciplinary case conference? That's one way to know if you're like a high volume center that's like
Okay.
doing it a lot, or if your surgeon attends that conference.
Yeah.
That's one kind of way to find out. Like, so always ask that. But in J-pouch surgery, there's no, like, I don't know, there isn't as much. And it's such a complex surgery that could literally change, like impact the rest of your life if something goes wrong.
This is so fascinating. You know what's unique is uh, in your specialty, it sounds like that's pretty amazing. I'm clearly not a colorectal surgeon. I did not know there was such thing as watchful waiting for colon cancer, and I did not know
Correct.
that J pouches are like so
Yeah.
not as frequently
I mean,
done
you used to
anymore.
think that's like a bread and but like it's
I
like
did more
bread
than
and
three in
butter,
my residency.
like bread and butter, like
Oh my God.
surgery. But now it's, I mean, the management has gotten so complex. There's so many different pathways. It's really gotten complex on not just the surgical level, but also the medical decision making. That you really need to be at a center that has expertise and a surgeon who, I mean, the number of patients, Shirin, I still see who have been recommended an APR, who don't need an APR.
That's completely removing their colon down to the rectum and closing the butthole.
Closing it up, permanent colostomy. Patients are being recommended this surgery still today in the US who like
Wow.
don't need that surgery. They can be reconnected.
Wow.
So,
But that's specialized. What do you think about the person who lives outside of
yeah.
somewhere near like a major city, um, who doesn't have access to that kind of specialty? Do you think they should I think they should at least go speak with a specialist and understand what the options are out there. And if they they therefore make an educated choice to go back to their hometown with their local doctor, that's fine. But I think you need to know. You need to know more. That's
Yeah.
the way I feel about it. Um, okay, should we do some questions that were submitted?
Yeah.
Okay. Uh, let's see. Hold on one second. Okay, there we go. How can you avoid an unending chain of referrals when trying to find the root cause of an obscure illness? Oh, I see. So you keep going. I think the problem is, well, I don't know really what this question is asking. I think when you have an obscure illness, you will be seeing multiple referrals because
Yeah.
it's obscure. So someone say, "Oh, this is a nerve problem. Go to this doctor. Oh, this is a hernia problem. Go to this doctor. Oh, this is a autoimmune disease. Go to this doctor." Like that's usually what happens. We don't have the privilege of one doctor knowing everything.
Um, which is a good thing with specialization, but is a bad thing with specialization in some,
Yeah,
right?
yeah. I feel like besides the fact that I think it's good to have specialists, I think it's also very important that specialists talk to each other.
Yeah.
So I learned from you when I refer patients, I don't just like send them out and don't talk about it anymore. I either come in the OR, see what you see and do, or I ask you like what your plan with the patient so I can learn
Yeah.
because I will have another patient perhaps similar. And then that way, when I see them, I can be a little bit more educated in the way that I discuss with them potential options and who they can see. So I think that we can definitely improve on in the United States. We're very siloed and we don't cross train. I would say though, you tell me how you feel about it. I think in private practice, we're a little bit more collaborative, I think, than not. It's easy to kind of be very siloed and not collaborate across specialties as much when you're employed.
It's even harder when it's across institutions.
Oh, true.
Right?
Yeah.
Which is probably why people, like the primary care doctor is going to refer you to his best friend, because then it's easy to get the information back from the best friend.
Yeah.
Right? Rather than like trying to find out who's like the specialist or the expert in this. I'm just going to say to my friend, because then at least the communication barrier is not broken. That's hacked because they can just text back and forth. Whereas if you have a person at, sometimes when I get like cancer patients and they're coming from another center where all their testing, their chemo, everything was done at another center, it becomes harder to like get all that information, like talk to who saw them and treated them to begin with.
It's true.
So that can be challenging.
Yeah, that's true. We do prefer to get as much work and specialists done within one institution system because of the medical records issue. Otherwise, there's a lot of work by the patient to keep taking all of their medical records to other people and getting and finding doctors that care to go through those medical records.
Right.
That's a lot of work and interest. I think that sometimes doctors are in a situation where their system doesn't promote sitting down with the patient for an hour and going through everything and leafing through and figuring out things because they have other responsibilities given to them, including like seeing so many patients or billing for so many hours. But when you don't have that kind of, I think that's one of the things I love about my current situation is I don't have that extra like pressure on me outside of what I do. So I spend as much time as I want with the patient.
Yeah.
It's really nice. Very grateful. All right, next question. What illnesses demand close cooperation between a colorectal and a hernia surgeon? Oh, fancy you would ask this question. We just spoke about it before we went live.
Yeah. So I did an operation on a patient who that surgery where the rectum and the anus all have to come out. This woman had an anal cancer and had to have her entire rectum removed and a colostomy, and she got a hernia into her perineum. So basically, she's got like a little lump hanging out every time she walks, like down where her rectum was. So I asked Dr. Towfigh if she can fix it, and she said she's done plenty of them.
Yeah, so perineal hernias are interesting because there's two types. There's three types now. There's the surgical one, like yours, right? There's all the prolapses, right? Rectal prolapse, vaginal prolapse, cystoceles, rectoceles, enteroceles, all those. Those are all in the midline, often due to either some congenital genetic laxity or because the patient had like multiple pregnancies and bad deliveries and so on. And then the third one are the ones at the side, which are what I call perineal hernias, that are primary perineal hernias. Those we don't know why people get it, like any other hernia. It's rare, usually poorly diagnosed. They have problems sitting and so on. So those I actually enjoy doing. They're very complicated because you have the rectum in the way, the bladder in the way, the uterus in the way, and then there's some nerves and vessels. There's a lot going on in the pelvis. And hernia surgeons in general are not as comfortable in the pelvis as, let's say, colorectal surgeons because we're general surgeons, and general surgery doesn't teach you, I think, the pelvis as well as the other parts, right? Do you agree with that? Yeah. So gynecologists, urologists, they work in the pelvis. Colorectal surgeons learn to work in the pelvis. But if you don't have those specialties, I think most people are uncomfortable. So over time, I've become comfortable because I do so much groin pain and pelvic pain stuff, but it's still like a tricky area. There's so much going on. But yeah, so the APR, those are, that's the problem with those is the muscle. Once you get rid of the anus, those muscles are really weak to begin with, and then they don't hold stitches very well. So they just loosen up. And the smaller they are, the easier they are to repair. It's the really big ones that are more difficult to repair.
I will tell you, Shirin, this woman has scleroderma. Does that affect anything that you would do?
Yes, maybe. Depends on how severe it is. So scleroderma is an autoimmune disorder. And in general, I don't like to put a lot of synthetic inflammatory mesh in patients with scleroderma. So we would have to err on using less inflammatory mesh products like the hybrid meshes. Still doable, yeah. But scleroderma is an interesting situation because it's both an autoimmune disease and a little bit of a, I think they also have a collagen disorder. I'll have to look that up. There's a combination of two things you don't want to have at the same time. Yeah. So it's mostly the perineal disorders.
Parastomal hernias. We also get parastomal hernias.
Parastomal hernias. Wow. So colorectal surgeons fix those as well.
Yeah.
And what's the thought in your specialty about a colorectal surgeon fixing it?
I think it's okay for us to fix it. I think again, more and more as hernia surgery has become specialized and there's so many different meshes and so many different things going on. I do have a tendency to refer those out too. I think there's a certain population that we hold on to, like our IBD patients, because we try to avoid putting mesh in those patients as much as possible.
Yes.
So we will frequently do like local tissue repairs and stuff on those, understanding that they have a higher risk of recurrence, but not wanting to put mesh in a patient with Crohn's disease if we can avoid it. I think when you have situations where the hernia gets really big and you have loss of domain, I think then it becomes really much more important that we have you guys on board. Because sometimes you might need like tissue reconstruction, component separation, other things to reconstruct a large hernia than just slapping a mesh in there.
Yeah.
And I think, again, like we don't do it a ton. So like if you're not doing something a lot, like why not let somebody who does it a lot do it?
Yeah, I would say that's very good that you say that. So I am super cautious about patients with inflammatory bowel disease.
Yeah.
Similar to the scleroderma patients, autoimmune disorders, you don't want to bring in an inflammatory product when they're already in an inflammatory state because higher risk of complications. And then specifically the Crohn's patients, I'm like, I don't even want to look at the bowel because I feel like just looking at it, you can cause a fistula. So why would I be that person that is causing so much potential injury? And once you get an injury from Crohn's, that patient's life is really messed up. So I don't want to be that surgeon. I'm very, very cautious. So we have different techniques, right? So the old school technique of peristomal hernia, it's not really that old school, but the laparoscopic technique is to put mesh on the inside. And so you have mesh against all the bowel exposed and mesh around the intestine. But now we have better techniques. Have you heard of the Pauli pre-peritoneal repair? It's a PPP repair. So Eric Pauli is a really smart hernia surgeon out of Penn State in Hershey. He was one of our guests, I think 2 years ago in one of our HerniaTalk lives. So he came up with this really cool technique, and I wonder what you think about it. So the stoma is kept where it is. The same way in a sugar baker where the stoma is, if you go backwards from the stoma goes down through the fascia, and then it kind of takes like this little loop, lazy S. That lazy S occurs not intra-abdominally, but one layer more superficial in the retrorectus space.
Yeah.
And then the mesh is also placed in the retrorectus space.
Well, that's interesting.
It's kind of cool.
Well, I'm forgetting that there's a name for that, for creation of a stoma with that technique, but I'm blanking on what that's called. Do you know what I'm talking about?
Oh, yes. You're talking about the preperitoneal pocket that it's
Yeah.
supposed to reduce. That's for primary stomas, right?
Primary
It's supposed
stoma
to,
surgery. What's that called?
so, I forget what it's called, but it's supposed to reduce the risk of peristomal hernia.
Right.
This is like a hybrid of those two concepts. You already have your stoma, you got the hernia, so then you move it into that space. But by default, your mesh goes extraperineal, but there's still a length of mesh that touches the bowel. So for the Crohn's patients, I just go anterior. So I do like an onlay. So the only part where the mesh touches the bowel is around the neck of it.
Yeah.
And so, and I use like a biologic, not a synthetic mesh. So there's no erosion risk.
Yeah.
There's so many things you got to do to be careful with patients like this. That's why you can't be a one-trick pony.
Yeah.
Yeah, because then you'll injure patients for sure. Okay, a related question to the previous one. What if you have seen multiple true specialists in multiple specialties and you get different recommendations from each one what to do to resolve your issue? That's a good question. I have patients that do that.
Yeah.
What do you think?
Oh, it's hard. Because sometimes there's not one answer.
Yeah. Yeah. And that's true. There isn't one answer. That's
So
a
I
good
think
point.
in that situation, I would just, like you got to go back and say, sometimes you can reconsult, like, not to become like, I don't want to say it, but like the annoying patient, but like you kind of want to become the annoying patient. You're advocating for yourself, right? So, hey, Dr. Zaghiyan, I saw you. This is what I recommended. I did go see a second opinion. This is what they recommended.
Yes.
What do you think of that? Right. And
I
then,
think that's good.
yeah.
I think you should pit doctors against each other in your consultation and get their opinion.
Yeah. Maybe somebody else had a great opinion that I didn't think about. I mean, we're not God. We're not, but it's possible for that to happen. Or that maybe there's a really good reason I didn't mention that other way. So you just, as long as you know it and you have asked, then you can make your decision how to move forward.
I agree. I think sometimes patients don't want to admit or show their hand that they saw other doctors besides you and they feel guilty or I don't know, they think
Yeah,
we don't care. I don't care. I would love to hear what I even ask. I said, like, who else have you seen about? Oh, doc. I've seen like two other surgeons. I always say, well, who are those surgeons? Because I want to gauge what their recommendation based on like what I know about them. Let's say,
Yeah.
and then I would say, oh, okay, so and so. Well, they're very smart or something like that. And I would kind of try and guide the patient a little bit to understand why I agree or disagree with the other surgeon's recommendation.
Yeah.
I don't take it personally that they saw someone else. I feel like patients think we take it personally.
No.
Okay, here's this interesting question. I have testicular pain. My scrotum was hit and injured 1 year ago. Initially, the testicular pain, whenever I moved, was severe, 9 out of 10 for a month. I couldn't sit for a single minute. 1 month later, the pain became less, 7 out of 10, but I still could not sit for 1 minute. After a colonoscopy in December 2024, the pain was better, 5 out of 10 when sitting, and I could sit for about 10 minutes. Why did the colonoscopy reduce my pain seemingly? Is it because of the lidocaine used during the deep IV sedation? What can I do to fully recover?
That's
I don't know the answer.
Interesting scenario. I think the pelvic floor like shares a whole nervous system, right? So it's not uncommon for somebody to have like, one pelvic problem have it affect the other. Like the common scenario, Shirin, about is like pelvic sepsis, right? If somebody has pelvic sepsis, if they have an infection in their rectum, they can't pee. So that's like, can't pee is a very common symptom of a severe infection in your rectum because of the shared nervous system. Or sometimes when we do hemorrhoid surgery on somebody and we've like cut into their anus, they can't pee afterwards. It's because those nerves have been shocked, they're affected. So that might be one possible explanation. Another possible explanation may be like, I don't know, if you were like really constipated, for example, and didn't know it, and then like the prep that you did for the colonoscopy maybe cleaned you out, and that was radiating to your testicle and causing the pain. My comeback question to that would be like, when I went down to 5 out of 10, did it stay a 5 out of 10 or was it short-lived?
Yeah, because maybe just anesthesia helped with pain around the time. But I do hear this though, that people get colonoscopies and well, one question is they always wonder, is it safe to have a colonoscopy while you have a hernia? What do you tell them?
Yeah, it's safe to have a colonoscopy.
Yeah. Unless there's all the colons in the groin. But short of that, it's safe. And then how does colonoscopy improve pelvic floor problems?
How does it improve pelvic floor struggles?
Yeah.
I don't know. I don't know. I don't know how I don't know how it would affect it. Again, it could be like a local pain thing. There could be some nervous, system thing where, maybe you were impacted with stool or you were constipated or something like that. And by doing the prep, now that's gone and that's not affecting the nerves and therefore it took the pain away from the testicle. I'm not sure.
I don't know, maybe it's just by chance because the pain, as a follow up, the pain increases from 5 to 7 if I sit longer. But maybe over time you're just getting better. You may have had pelvic floor injury when you got hit in the scrotum. Is that possible? And that's just getting better. That's why sitting hurts. Sitting shouldn't hurt. Sitting usually hurts if there's you get patients that have pain when they sit.
So the testicle hurts when he sits?
No,
or his anus hurts when he sits.
Oh, maybe it's unclear. Maybe he can clear it up. Initially, the testicle pain was severe. I could not sit for one minute. So the question is the testicle pain severe when you're sitting, or you can't sit because of like pelvic floor pain? Then that could be an injury. Yeah. Let's do some more questions. What are the hernia and colorectal related illnesses in which a surgeon's specialization is essential to maximize the chances of a positive long-term outcome? I think it's these random ones, right? If you have colon cancer, obviously it's better to go to a specialist, but that's not as important than maybe like someone with Crohn's disease, or is it all important?
I think colon cancer, if it's straightforward colon cancer, probably is okay, not done by a specialist. Again, specialist expertise, it does, I think, impact outcomes, but is it like critical? Probably not as much as it would be for Crohn's, as for rectal cancer, as for a J-pouch operation, something like that. Again, just like most things, like doing a really high ligation of the nodes, right? Maybe that's not something your general surgeon is going to do. It depends on how much cancer your general surgeon does. Is your surgeon doing the surgery robotically? Like, how are they doing it? There's a lot, I think, again, like things that like we learned in our general surgery residency have become so complex. Like, look at breast cancer. Like, we used to do that all the time. Like, I would not know what to do with a breast cancer today.
Yeah, it's totally changed.
So much. So that's kind of what happens, is like something that you learned, evolves. And if you're not a specialist in that thing, you don't evolve your technique. You keep doing it the same way that you learned how to do it, years ago, and you haven't really kept up. That's the issue with like non-specialization, even for some of the more simple things.
Yeah, you're so right. I would say that Like if I did a colorectal cancer, let's say I was a general surgeon that did more than just hernias, then the likelihood is if I was just like someone in the community that I would just do it the way I was trained to do it.
Yeah.
Whereas a specialist that goes to meetings and keeps up with the times and has to recertify their boards and all that, you would know that you have to take X number of lymph nodes and go this far away from the colon, and there's much more nuance to it. Maybe you have a lower risk of complications. Is that true?
I mean, I don't know if there's a study that's like looked at, general versus colorectal surgeons in colon cancer
Yeah,
necessarily, but there has been studies that have looked at it in rectal cancer, like the number of cases done annually actually affects, outcomes.
yeah.
Um, um,
So there's a trend, I'll tell you this, a trend towards trauma surgeons trying to become hernia surgeons because
oh,
they're tired of
causing
taking
a hernia
call. Huh?
because they're causing so many hernias.
They cause so many. It's true. That's true. So trauma surgeons are the number one specialty that um, they have the highest rate of hernia,
Yeah.
incisional hernias, I guess is what you call it. That is true. But you know who's number two?
Hilarious.
Colon cancer. Yeah, colon surgeons.
Colon.
No. So anyway, so they're getting older and they don't want to take call as much anymore, and it's just draining. So what else can they do? Maybe I'll be a hernia surgeon. So a lot of them are moving into the hernia surgery world. But guess what? They were trained to do hernias like 30 years ago when they were a resident. So I literally get phone calls about things that are like huge no-nos in our world, like using a mesh plug. No one puts a mesh plug anymore. Like you really shouldn't. I know they still do, but you shouldn't. Or we're trying to reduce how much mesh we put intraperitoneally, like exposed to the bowel. We're trying to not do that. And yet both of those were like commonplace when I was a resident. And
Yeah.
therefore these doctors were like, I don't understand, why can't we do this? And I would try and explain to them, and they're still like, I don't get it. I think it's just fine. Like, oh, how are you going to be a hernia surgeon? I need you to go to some classes, go take some courses.
Yeah. Are
Crazy.
you seeing less hernias as we're doing, like, if I'm doing an operation, right? Like, I'm always, if I need to make an extraction incision, I'm always trying not to place it midline. Like, choose a fan and steel because that
Yeah,
has a lower rate of hernia. Off midline, lower rate of hernia.
yeah,
Um, Obviously, smaller incisions, laparoscopic robotic surgery. Are you seeing less
yeah,
hernias?
yeah, we are. So less open surgery for sure. And then the colorectal surgeons showed that if you want to remove the colon through an incision, let's not take it out of the belly button. Let's take it, suprapubic incision, like a C-section scar. That's dramatically reduced hernias. The same is true of the urologists that take out the prostate. So they do everything robotically, minimally invasively, but they still need to make an incision to take out the prostate. Now that their consensus reports confirm that it's best to take it out, similar to the colorectal surgeons in a suprapubic manner. So yeah, all of those are true. Yeah, we have less. Even the spine surgeons, when they do these lateral approaches,
Yeah.
they were taught to do it a certain way, but they were taught by a fellow neurosurgeon, which was incorrect. And so we published our paper, and I gave like grand rounds at our own spine surgery conference. I'm like, stop doing this. You got to use this type of suture and put them through these type of muscles. And I was seeing, I think we had the largest series of hernias after spine surgery published, and now I see very few because they all changed their technique, so it all makes sense. And I was seeing a slew of urologists having hernias after prostate surgery, and now, you know, you just change your technique. Another question, specific hernia related question. I know each case must be individualized, but if you had primary hernia repairs and then another groin surgery for recurrence complicated by pain, given fibrosis and the activated nervous system with sensitization and centralization, how do you decide when to attempt a surgical revision to reduce pain versus giving up and going for a spinal cord neuromodulator. Do you have patients that require spinal nerve stimulators for colorectal problems?
Mm. I have patients that have them, but not
Yeah.
require them. We put sacral nerve stimulators for fecal incontinence.
And how does that work?
We don't know.
Oh,
We don't know. I mean, it modulates the third sacral nerve, which we know controls the rectum. It controls the bladder.
uh-huh.
But fun fact, we're actually doing a clinical trial right now studying to we're using it in our IBD, in our ulcerative colitis patients,
Uh-huh.
because it's thought that when you stimulate the sacral nerve, that there's a reflex arc to the vagal nerve that then is immune modulating, and that it actually helps minimize the inflammation in the gut. So we're implanting this in patients with urgency. They're seeing not only a decline in their urgency symptoms, but we're actually also seeing that when we scope them, we do colonoscopies on them, they have less inflammation. So it's a huge area of like, we don't understand, but it's so cool and fascinating.
Wow.
Yeah.
Wow. So if you stimulate the vagal nerve, that could be immune modulating?
Yeah. Mhm.
Isn't that what they do for the gastroparesis patients?
I think so. Yeah.
We live in a fun world, I tell you. Okay, I think we have some more questions. Let's see. Are there any kinds of hernias better treated by a colorectal surgeon than a specialized hernia surgeon? Hmm. I would say all the prolapses.
Yeah, I mean, we do all the prolapses. I'm doing one Friday. It's a combined repair with our urogynecologist. We usually tag
Yeah.
team it.
Yeah.
Um, those are
How
also,
do you tag team it? What do you do and what do they do?
so we do, so the gold standard for a rectal prolapse has now become a ventral mesh rectopexy. So we use a lightweight polypropylene mesh. We open up the rectovaginal septum, like to separate the vagina from the rectum all the way down to the pelvic floor, put the mesh on the rectum, use that up and secure that to the sacral promontory. And then if the patient still has their uterus in, they'll remove the uterus and then attach a mesh to the cervix. And then they'll put their mesh onto our mesh so that the whole thing gets pulled up. And then we close the peritoneum and repair the enteroceal over all that. So the mesh all gets covered into the like into that space. So it's not,
And you're sewing bare mesh onto the colon?
yeah, it's a lightweight polypropylene mesh. We've used the various kinds of like biologic mesh. It just doesn't work. Even the half
Oh,
biologics, they don't work.
oh, even the hybrids don't work?
And the hybrids don't work. So it's kind of become accepted and the gold standard that if you use a lightweight mesh that's porous, obviously you're not going full thickness into the rectum. You have to take like, seromuscular bites. Um, but yeah, that's what we use. And then they put the same mesh on top of ours. The whole thing gets covered up. And it has the most durable, like long-term results. The problem with prolapse repair in general so mesh has made a full circle in prolapse
Yeah.
surgery. To put like meshes wrap it around the rectum, that was causing a stenosis, that was causing, all the pelvic mesh complications that was all over the news. We went away from mesh for a long time. We were doing resections of the colon, like resection rectopexies, where we were
Yeah.
resecting the colon that was prolapsing and then tacking the rectum up. But people were still getting a recurrence. And so we've gone back to that cul-de-sac is like the lead point where all the bowel falls in there and like pushes
Yes.
everything out. And so
Mhm.
if you want to repair the prolapse, you have to go at it in that plane and you have to support that plane completely and pull it up. And it's best to do it together if if the patient has both a middle compartment and posterior compartment
And
prolapse.
then isn't the small bowel exposed to the mesh too?
No, because you cover the peritoneum, you close the peritoneum over.
Okay. It's extraperineal. Got it.
Mhm.
Okay. Still makes me nervous putting mesh on bowel. even the colon.
Knock on wood, I know.
Although we do it for parastomal hernias.
Yeah.
But yeah. Okay. Oh. I do not believe you addressed my previous question because you got distracted by the vagal immune interaction. What was the last question? Oh, yes, sorry. He's right. It was about whether you should go in and reoperate on someone who already has a lot of chronic pain and maybe centralization of pain, or do you move on and just do a spinal cord neuromodulator? I would say that depends. If there's a clear, obvious reason, then with the involvement of a pain management doctor, with the use of maybe ketamine and other things that can kind of reduce your chronic pain situation, I would operate. I'm not a big fan of spinal cord neuromodulator unless it's for end stage process. So if it's a treatable problem, so I'll give you an example. I had a guy who was so debilitated, he was on his knees on the in the exam room, crying in pain. Like that's how much pain he was in. He had made like a sling, like a hammock for his scrotum because the testicular pain was so severe. What he had was a hernia repair that completely kind of was guillotining through his spermatic cord. And they told him he needed he had too much chronic pain. He needed a nerve modulator. And what he really needed was a mesh removed because it was totally a mechanical issue. So that's my kind of bent, which is if there's clearly a reason that can be removed. It's like giving you pain medication when you have a rock in a pebble in your shoe.
Yeah.
Just take out the damn pebble. Even if you have a lot of chronic pain, I think in those situations they still do well. But if you're dealing with nerves and you have chronic pain, the risk of CRPS, right, the complex regional pain syndrome, is slightly higher. So I get nervous about those. All right, shall we do one more question?
Sure.
Let's see. In patients requiring surgery for both a colorectal disease, excluding cancer, and a hernia, does addressing the colorectal disease always take precedent if treating them in a, what's the rest of the question? Gotta look up the original question. Well, let's just say if does always take precedent if treating them in a sterile manner. Or I don't like doing hernia surgery at the same time as colorectal surgery. Some people do it. Kind of
If
violates
someone
my
had like recurrent bouts, let's say diverticulitis, someone has diverticulitis and like they've had a few attacks, they're considering maybe surgery and they have a hernia, what do you do in that situation?
I mean, deal with the colorectal procedure, which is removing the disease portion.
If it wasn't for the hernia, like they don't necessarily need to have surgery. It's an option, but they don't have to have a colectomy.
Okay, that's a good question. So I do discuss with patients that predictably will need another surgery about the importance of understanding that if I do let's say, abdominal wall reconstruction, I don't want anyone else to go through that if possible, right? So so if they have someone who has recurrent gallbladder attacks or recurrent diverticulitis attacks and so on, the worst thing is for me to do this beautiful hernia repair with mesh and then have them have another bout of diverticulitis and need colorectal surgery at that time. And now you're not only going to disrupt my repair, you may even infect my mesh. And that's a disaster. So I do have that discussion. I feel that discussion is not made enough.
No.
And there are tons of surgeons that are hernia surgeons that believe bigger is better. They'll put mesh all over. And I've literally told them I don't think that's fair to the patient because they're going to need gallbladder surgery, colon surgery, appendix surgery, something, and now you're putting them at a higher risk for the other surgeon, and they're like, sucks to be them. Like, so inappropriate. I don't know. Do you agree with that? Would you be pushed to fix a would you be pushed to operate on someone if I said I need to fix their hernia, but I don't want to
So I think
risk
if it
that?
was I think if it was a reasonable, like if they had a single attack of diverticulitis, I wouldn't go doing a colectomy, because they had a hernia. But if they had had a few attacks and otherwise
Yeah.
I would say it's your choice, I think I would kind of push them to just moving forward with it so that it's not an ongoing issue. I mean, we think less that somebody who presents with uncomplicated diverticulitis could have like a complication of diverticulitis that we used to worry that you'll perforate, your bowel will rupture.
Yeah.
And we don't think so as much anymore. It's just like the new nuisance of like another flare, another flare. But if it's happening frequently enough that it would be reasonable to do the surgery, I think I would kind of push them into doing it. Not push, but like,
Before we leave, I really want you to be able to see if you can help this patient. Um, this is a patient with the scrotal injury or
oh, uh-huh.
pain sitting. He says, I cannot sit because of ongoing scrotal and perineal pain
Oh, interesting.
after injury to my scrotum and testicle. The posterior scrotal nerves and perineal nerve may be irritated or compressed. Will doing a spermatic cord nerve block help? Is scrotal nerve or perineal nerve block available? What kind of treatments are available? What's your take on that?
I think so. I would get like imaging, like an MRI or something. I forget if he said he'd had that, just to make sure there's no actual, like a real injury, like
Yeah.
a fistula, like a sinus or something that's like not coming to the skin, that's causing an infection or something down there that's causing those symptoms. I do that first. And then I really like pudendal nerve blocks
Mm,
for our, anal and pelvic
yeah.
floor pain patients. Um, I think pelvic floor PT is really useful. A lot of patients will have a levator spasm or like a spasm of their pelvic floor that can be therapied out with like a massage or other kinds of treatments.
Suppositories.
What?
Muscle relaxant
Muscle
suppositories.
relaxants can be great. Yeah. I think those are the next steps. I would have them make sure they do like a thorough anorectal exam to make sure there isn't some other, they don't have a fissure or like there isn't some other thing that's causing pain that's gone missed.
Yeah.
Yeah.
Yeah. No, I totally agree. Yeah. It sounds like focusing only on the testicle and scrotum is not necessarily the best. So spermatic cord block can be done to see if there's any injury to your spermatic cord, um, causing the testicular pain, but the pudendal nerve block. What's a perineal nerve block? Is there a perineal nerve? There's a peroneal nerve, but I don't think there's a perineal nerve. I think it's a
No.
pudendal nerve.
Yeah.
Yeah. Okay, my friend. Well, I'm so glad that you accepted my invitation. If you do any more rants on TikTok, you can join me again. This was so much fun, Karen. Thank you
It's
so much.
really fun. Thank you so much for having me.
Yes. Well, that's the end of Hernia Talk Live. Thanks everyone for joining and for asking questions. Don't forget, watch and share on my YouTube channel or as a podcast. And next week I will be out of town because we have the American College of Surgeons meeting. So I will see you the following week and hopefully with a great guest. Looking forward to it. See you guys. Bye.